My name is Elise Worsell, and I am an infectious diseases and internal medicine doctor at Boston University School of Medicine and Boston Medical Center. I have about 15 years of experience as a doctor and a researcher working to improve healthcare in the carceral system. The criminal legal system is broad and spans interactions ranging from arrest to incarceration and experiences post-incarceration like parole and probation. The U.S. incarcerates more people than any other country. Exposures to the criminal legal system is common, especially for people with substance use disorder and alcohol use disorder. The opioid epidemic and high rates of post-incarceration death from overdose spurred attention to the importance of offering evidence-based treatments like medications for opioid use disorder during incarceration. Less attention has been spent on offering medications that treat alcohol use disorder in people who are incarcerated. There's less data on the prevalence of alcohol use disorder in criminal legal populations, but the overlap between alcohol use disorder and other disorders, as well as the criminalization of certain alcohol-related activities like driving while intoxicated, lead to high rates of alcohol use disorder in the carceral setting. If people are incarcerated and have a history of alcohol use disorder, they are monitored and provided with medications per withdrawal guidelines. There has long been an appreciation of the potential severity of untreated alcohol use disorder. The June 2023 interdisciplinary release of the guidelines for management of alcohol use withdrawal in jails recommends evidence-based interventions including CWIS scale monitoring and long-acting benzodiazepines. Several FDA-approved medications are available for the treatment of alcohol use disorder, including extended-release naltrexone, disulfiram, and acamprosate. The National Commission on Correctional Healthcare, MAT substance use guidelines, cite that naltrexone and acamprosate have evidence for supporting recovery in the outpatient setting. Unlike medications for opioid use disorder, there is no guidance on how to operationalize alcohol use disorder treatment in jails and prisons. One of the challenges to seeing people in jails and prison with a history of alcohol use disorder is that in that moment, they are likely to be in the post-withdrawal period. Discussions about alcohol use disorder treatment can be challenging because the patient often reports that they feel like the experience of incarceration is an interruption in alcohol use that they will use as momentum in sobriety or reduced drinking after being released. One tool that clinicians can use to address this is to build rapport with the patients by supporting them in their recovery while also engaging in discussions about how a multifaceted approach will help them support long-term recovery. Medications will not replace the patient's dedication, but may enhance treatment and potentially fast-track recovery and reduce drinking. In particular, the long-acting injectable medications such as extended-release naltrexone can provide people who are leaving jail or prison extra support in decisions to curb alcohol use. Another challenge is the timing of long-acting injectable medications. Optimally, extended-release naltrexone would be injected before release. The timing of release, especially for people who are pre-trial and people incarcerated in jails, is often not known. Initiating people on oral treatment with naltrexone or acamprosate and providing medications in their belongings for them to access after release from jail or prison is one way to counter this concern. Another challenge is that people with alcohol use disorder may often have co-occurring substance use disorders. They may not be ready to abstain from alcohol, even if their goal is abstinence from opiates, stimulants like meth or cocaine, or sedatives. Alcohol is often seen as a less harmful drug, largely as it relates to society's acceptance of alcohol versus drugs like fentanyl or crack cocaine. Ordering lab work, such as a hepatic panel, clotting labs like INR and platelets, and an albumin can be helpful in showing people who use several types of substances that alcohol is damaging. Many do not see or feel the impact of alcohol use, and ordering lab work including an AST or an ALT, which are hepatic enzymes, can be a way to start the conversation about the impacts of alcohol on liver inflammation. The caveat, however, is that lab abnormalities are often a late manifestation of alcohol use disorder. Normal levels cannot rule out that alcohol is causing damage to the body. Lastly, clinicians may feel that they offer medications for alcohol use disorder and the patients say they are not interested. This may lead to clinicians not offering medications. Medications for alcohol use disorder are less widely advertised. Even if the patient says they are not interested, providing them with the education that these medications exist and can be a vital interaction for promoting reduced alcohol intake and recovery is important. Incorporating tools of motivational interviewing can assist in moving people from pre-contemplative stages on medication for alcohol use disorder to later stages of behavioral change. It is worth explicitly saying that medications for alcohol use disorder, like acamprosate and extended-release naltrexone, can be used for people who are interested in reducing drinking, even if they do not want to stop drinking. People who are incarcerated should receive the highest level of evidence-based healthcare. Assessment of the impact of alcohol use disorder on their body and offering medications that are evidence-based practice are crucial parts of supporting someone in recovery.